Welcome to another episode of Humans vs. Machines, the medicine debate, where clinical judgment, cutting-edge tech, and ethical gray zones collide. I'm your host, Dr. Matt Sage, internal medicine physician, data ethics nerd, and your guide through the thorniest questions facing healthcare today. Today's question is one of the most chilling, consequential, and current. Should AI decide who gets an ICU bed? It's the stuff of both innovation and nightmares, life or death decisions guided by code, algorithms, crunching numbers like age, lab values, organ failure scores, comorbidities, and outputting a rank, a score, a priority. But is that fairness? Or a cold arithmetic that forgets we're more than our vitals? In times of crisis, pandemics, disasters, ICU overflow, decisions need to be made fast. Too fast sometimes for nuanced human deliberation. But hand over that power to AI, and we're forced to ask, can it weigh hope, context, complexity, the very humanity behind the data? To help us wrestle with this ethical and clinical juggernaut, we've brought in two of our sharpest minds, who couldn't see this issue more differently. First, joining us from Austin, Texas, we have Dr. Javier Delgado, a critical care specialist and clinical AI researcher. Known for his dynamic advocacy of data-driven triage systems, he believes AI can bring order, transparency, and life-saving precision to one of medicine's hardest calls. He's seen frontline chaos during COVID surges, and now builds systems he believes will keep doctors from having to play God. When asked if he'd trust an AI to triage his own care, he famously replied, "Only if it was trained on enough real-world chaos to understand how messy life is." Opposing him from Atlanta, Georgia, is Dr. Aisha Bennett, a veteran intensivist and hospital ethicist who has spent her career at the bedside, refusing to reduce patients to prognosis scores. Dr. Bennett argues that AI can assist, but never decide, because the ICU isn't just about odds. It's about values, narratives, and the sacred duty of being human in the hardest moments of care. She once told a group of trainees, "The day I trust a machine to speak for a patient who can't speak for themselves is the day I've stopped being a doctor." These two clinicians bring not only sharp minds, but lived experience from opposite ends of the data-humanity spectrum. And today, they'll square off in one of our most high-stakes debates yet. Before we begin, we polled our audience. Here's where the numbers stood. 26% said they believe AI should be allowed to decide who gets access to ICU care under clear conditions. 59% said no way, humans must always lead. And 15% were undecided, willing to be convinced. Now it's time to test those beliefs. Coming up next, opening statements from Dr. Delgado and Dr. Bennett. You'll hear their unfiltered positions and decide which vision of the future you're willing to live or die with. Now, let's hear from our debaters. They'll each have 5 minutes for an uninterrupted opening statement. First up, speaking in favor of AI-driven ICU triage, Dr. Javier Delgado.
Thanks, Dr. Sage. This is a heavy topic, but it's one we can't afford to avoid. Let me start with a memory from the peak of the COVID-19 pandemic. I was in the ICU. We had 4 beds and 10 patients who needed one. We had to make triage decisions on the fly. And guess what? Everyone, myself included, relied on a mix of clinical scoring tools, gut instinct, and personal experience. We did our best, but we were also guessing under pressure, emotion, and fatigue. That's why I advocate for AI, not as a replacement for human doctors, but as a tool for fairness and consistency when the stakes are highest. Here's what AI can offer. Objectivity. Human decisions are shaped by bias, conscious or unconscious. Numerous studies have shown disparities in ICU allocation based on race, socioeconomic status, even language. A well-designed algorithm can minimize that. Speed and scalability. During crises, we don't have the luxury of hour-long consults. Algorithms can analyze vast amounts of data, SOFA scores, lab trends, comorbidities, and prioritize efficiently. Transparency. Contrary to the idea that AI is a black box, many modern systems are explainable. They offer traceable logic, more traceable than subjective bedside decisions. Let's be clear, these systems aren't perfect, but neither are we. What they offer is consistency. If you want to be triaged fairly, regardless of where you live or who's on call, you want a system that behaves the same at 2 a.m. as it does at noon. And for those who say, but what about hope? What about the human story? My answer is, hope has to live in the care plan, not in the allocation grid. Triage is a cold reality. We need warm follow-through. Let humans do that, but let AI help us start fair. Thank you.
Thank you, Dr. Delgado. Now, let's hear the opposing view from Dr. Aisha Bennett.
Thanks, Matt, and thank you, Javier. You described the chaos of COVID well. I was there too, in the ICU, having the same impossible conversations, but my takeaway is different. Here's the thing. Triage isn't just logistics, it's ethics, it's humanity. When I make a decision about who gets a bed, I'm not just weighing scores, I'm weighing stories. The 42-year-old single mother with a 50% mortality score, but with a 10-year-old son who visits every day and gives her a reason to fight. The undocumented man whose medical history is blank, but who has family waiting at his bedside. I can't see that. I can't feel that. Here's why I believe humans must always make the final call. The data isn't enough. Algorithms rely on structured data, creatinine, oxygen saturation, age, but many patients don't fit cleanly into those boxes. What about undocumented patients? What about cultural contexts? What about people who have poor documentation because of systemic barriers? Bias still seeps in. AI is trained on real-world data, and that data already reflects bias. If the dataset shows worse outcomes for certain groups because of systemic racism, the algorithm learns to deprioritize them. That's not objectivity, that's automation of injustice. The role of judgment. Some things can't be coded. How much does the family understand? What are the patient's goals of care? What's the trajectory, not just the snapshot? Those are human judgments. We already have decision tools, SOFA scores, Apache, etc. They're helpful, but they're not deciders. They're advisors. Let AI assist, but not replace the moral labor of doctors. Because when a family looks me in the eye and asks, why wasn't my mother given a chance? I need to be able to say, I made that decision and I stand by it, not the machine said so. That's what accountability means. That's what medicine means.
Powerful opening statements. One future guided by speed, objectivity, and data. Another held together by narrative, ethics, and accountability. Next, our debaters go head-to-head, pushing each other's positions to the edge. Stay with us. Welcome back. In this round, our debaters will engage directly. No prepared notes, no slides. Just the core ideas clashing head-on. We're starting with the question, can AI understand fairness? Let's begin.
Absolutely. Fairness in medicine has always been a moving target. We strive for equity, but humans are not unbiased. Look at the evidence. Black patients are less likely to receive advanced cardiac interventions. Women are less likely to be triaged as high acuity in emergency settings. AI gives us a shot at standardizing triage, same inputs, same outputs.
But that's illusionary fairness, Javier. AI might be consistent, but consistency with flawed logic is still flawed. You mentioned race. Yes, it's true there's bias in care. But if we train an algorithm on biased outcomes, it will replicate those disparities. What we need is not blind consistency, but moral discernment.
You're assuming the data isn't fixable, but we can audit algorithms, we can retrain them, and most importantly, we can design them to be transparent. That's the difference now. We're not talking about black box models anymore. Explainable AI can show you why it made the decision. Can every doctor do that at 3 a.m. under stress?
What you call explainable still can't account for context. Let me give an example. Two patients. Both have multi-organ failure. Both have 60% mortality. One is an undocumented worker with no family. The other is a retired professor with pages of medical records. AI sees numbers. I see that the undocumented patient has a shot. He's young. He has no history of illness. He's strong. That's clinical intuition and justice, not favoritism.
Let's pause there. Aisha, do you believe that judgment should vary across providers? Isn't that where the inconsistency creeps in?
Absolutely. And I embrace that, because patients are not widgets. Each decision requires understanding their story. Let me be clear, I'm not advocating for chaos. We already use scoring tools. But I oppose removing the clinician from the final judgment. That's where the soul of medicine lies.
But what about capacity? When beds are full, when systems are overwhelmed, like during a mass casualty event, can you truly give every case the time it deserves? AI isn't just about fairness. It's about functioning in crisis mode. We need decision support that is fast, scalable, and unemotional when necessary.
I agree with the need for speed, but not at the expense of humanity. Speed and empathy are not mutually exclusive. During the Delta wave, I had 5 consults in 30 minutes, but I still looked at each family, each patient, and made my calls with eye contact, not an API call.
That's admirable, but not sustainable. We lost people because of system overload. What I'm saying is, AI could have helped us prioritize better. If we had used algorithmic scoring tools as the initial sieve, we could have spent our limited time on the patients with real ambiguity. AI handles the predictable, humans handle the nuance.
Let's pivot slightly. How should these decisions be communicated? If AI contributes to the triage choice, should families be told?
Yes, transparency is essential. We need to explain that an AI-assisted triage tool was used, that it is part of the system's standard of care, and that clinicians reviewed its output before making the final decision. Families deserve honesty, but they also deserve a system that works.
But we know how families react. Imagine telling someone their loved one didn't receive ICU care because an algorithm said no. You can explain it all you want, but the emotional damage is done. It sounds impersonal, like a dystopian nightmare. The human voice in that moment matters.
Javier, do you believe a hybrid model is the ideal future? AI first pass, human final review?
Yes, 100%. That's the middle ground. We're not eliminating humans, we're elevating them. Think of AI as triage infrastructure. It filters, it stratifies, and it flags inconsistencies. Humans bring the judgment. That's how we scale wisdom, not replace it.
And my concern is, the moment we outsource the first pass, we risk letting inertia guide decisions. The more we rely on AI, the easier it becomes to stop questioning it. That's the danger, overtrust, and that's how clinical ethics erodes.
A compelling clash. On one side, AI as scalable fairness and structure. On the other, the irreplaceable judgment of bedside medicine. We'll dig deeper into real-world case studies and ethical dilemmas in our next round. We're back with round 2 of our head-to-head. In this segment, we'll anchor the conversation in real-world scenarios, including recent cases of pandemic triage, transplant allocation, and scoring system controversies. The question we'll tackle now: what happens when real lives meet algorithmic logic?
Let's start with reality. During COVID-19 in Italy and later in parts of the US, hospitals created makeshift scoring systems to allocate scarce ICU beds. Some used criteria like age, number of comorbidities, SOFA score. These tools worked, but inconsistently. Imagine if we had an AI model trained on millions of ICU admissions, refined to learn which factors predict true survival, quality-adjusted life years, and trajectory. That's not theoretical. Systems like the Israeli Maccabi Healthcare AI model already predict 90-day mortality with high accuracy. In triage, that kind of forecasting could help us save more lives overall.
Yes, and that same Maccabi model was trained on structured EHR data from a system with universal healthcare, strong documentation, and relatively low diversity. What happens when you apply that model to a hospital in Detroit, or a rural center in Appalachia, or a safety net hospital in the Bronx? The predictive accuracy drops, the risk of misclassification rises, and here's the chilling part. When you're wrong in triage, someone dies.
That's why we localize models. No one's suggesting we lift and shift blindly. We need models built from diverse data sets, validated in the populations where they'll be used, and constantly monitored for drift and bias. But that's not a reason to throw them out, it's a reason to make them better.
I'll give you a counterexample. The SOFA score itself. Originally developed for sepsis monitoring, it's now widely used for triage, even though its correlation with mortality is far from perfect. In COVID, many Black patients had higher baseline creatinine levels, and SOFA penalized them unfairly. An AI model using the same inputs would make the same mistake at scale.
True, and that's why we must use algorithmic fairness audits. The NIH now mandates equity checks for AI models in research. Newer frameworks like equalized odds or demographic parity are emerging to correct this. The future is not biased algorithms. It's audited, explainable, and correctable ones. Compare that to human providers who rarely self-audit and can't be version controlled.
Okay, but let's zoom in. Imagine you're the doctor on call. An algorithm says patient A should get the last bed. You disagree. Do you overrule it? And if you do, are you liable if the patient dies?
That's a valid concern, but think of AI as decision support. It's not binding. It offers a probability score, a risk assessment, not a command. The clinician should always have override capability, and our legal systems must evolve to reflect that nuance.
Let's move to another example. Organ transplant allocation. United Network for Organ Sharing, UNOS, already uses predictive scores like MELD. Should AI expand its role here?
No, organ allocation is more than stats. A 40-year-old with alcoholism and low family support may score well on MELD. But what if you know they've relapsed twice and missed prior clinic appointments? Human insight matters.
And yet human insight has also led to disparities in who gets listed. Minority patients wait longer. Wealthier patients navigate the system better. AI could flag those inconsistencies. It's not perfect, but it helps expose the hidden biases in our human decisions.
Only if we build it to do so. That's the challenge. Who trains the model, what data we feed it, and whether we're honest about its limits. Otherwise, we risk embedding existing inequities behind a veneer of objectivity.
Let's wrap this segment with one final point. Should patients be able to opt out of AI-based triage tools?
No, not in crisis scenarios. If we allow individual opt-outs during a system-wide emergency, we undermine the fairness of the process. Everyone has to play by the same rules.
I disagree. Patients deserve autonomy, especially in critical care. At a minimum, they should be informed when AI is used and have a say in whether it plays a major or minor role.
That was a fast-paced 10 minutes with huge ethical weight. AI as a necessary evolution, or a dangerous shortcut. Coming up next, it's time for the gloves to come off in our Crossfire round. Welcome to the hot seat. In this round, our debaters go rapid fire, posing pointed questions to each other, digging deeper into assumptions, logic, and personal conviction. Javier, Aisha, no scripts. Let's keep answers crisp, but don't hold back.
Aisha, do you believe it's ethical to let two doctors in different hospitals make opposite decisions about identical patients based purely on subjective judgment?
I believe context matters. A rural doctor might know a patient's resilience, social circumstances, or past medical trajectory in ways data can't capture. That's not unethical. It's personalized care. Would you trust your own loved one's life to an algorithm without human override if they were in a life or death situation?
Absolutely not without human override. But if the algorithm flagged them for ICU and a clinician confirmed the fit, yes, because I'd know it was evidence-driven, not emotional guesswork. If you had just one ICU bed left and 5 patients needed it, would you feel confident making that decision without any algorithmic support?
I've done it, and yes, not because it's easy, but because I know what matters. I factor in their prognosis, trajectory, family support, goals of care. Tools can assist, but never replace moral reasoning. Javier, you say AI offers transparency. But can the average clinician explain how a gradient-boosted decision tree or neural net arrived at a conclusion?
They don't need to explain the math, just the logic pathway. Many systems now offer explainable outputs, like SHAP values or probability weights. It's like using a drug. You may not understand the chemistry, but you rely on proven effect and oversight.
Let's up the stakes. One question for both of you. No dodging. What's the worst-case scenario for your position?
The worst case for AI is if we deploy it without proper governance, biased models causing systemic harm at scale. That's why testing, oversight, and clinical override are essential.
The worst case for human-led triage? Burned out clinicians making snap calls under pressure, inconsistently and unfairly. That's real. We need decision support, but the final call must come from a human heart.
A fierce exchange, neither side backing down, because lives are at stake, and the future of triage hangs in the balance. Up next, your questions, their responses. Stay tuned. Welcome to Segment 6. You've heard the opening salvos, the clash of logic and ethics, and the crossfire. Now it's your turn. These are real questions submitted by clinicians, ethicists, and students from across the U.S. Let's dive in. Dr. Lena Morales.
I've used both AI-based risk stratifiers and traditional clinical scoring systems in the ED. What I struggle with is liability. If I follow the algorithm and something goes wrong, am I protected?
Great question. Right now, the liability framework around AI in medicine is evolving. If AI is integrated into the system's standard of care and clinicians follow reasonable judgment incorporating AI, liability is shared or may even fall on the institution or vendor, depending on state laws. That said, documentation is key. If you rely on an algorithmic recommendation, make sure your clinical reasoning, agreeing or disagreeing, is clearly recorded.
Exactly. And Lena, remember, delegating judgment does not absolve responsibility. The law may lag behind the tech, but the standard remains that you must act in the best interest of the patient. I'd recommend using AI as a second opinion, not a final voice.
Devin Hughes.
Can you speak to how AI models adjust for patients who are marginalized or underrepresented in data sets? How do we ensure justice in triage?
Devin, excellent concern. Justice in AI begins with diversity in data. If training data is skewed, the model will reflect that. So efforts are underway to build multi-site, demographically diverse data sets. NIH's Bridge 2 AI initiative is a great example. We also have fairness algorithms, like counterfactual fairness and equal opportunity scoring, designed to detect and correct bias. But the key is auditing continuously, not just at launch.
And we must stay critical. Even with fairness layers, models often learn proxies for race, language, or income indirectly. Justice is not just mathematical, it's relational, which is why diverse clinician input in design and deployment is non-negotiable.
Dr. Brian Okiki.
What's your response to the idea that AI can depersonalize end-of-life care? Triage isn't just about who lives. It's also about how they die.
Brian, I deeply agree. I've held the hands of families as they made those decisions. There's a sacredness to how we guide people through death, and it's hard to imagine an algorithm navigating the nuances of faith, cultural values, and family dynamics. AI may suggest a ceiling of care, but only humans can close the conversation with grace.
I respect that deeply, but I'd add, depersonalization doesn't come from AI. It comes from overwhelmed systems. If AI can support clinicians by flagging when palliative care may be more appropriate, or when a patient has no meaningful chance of recovery, then the human conversation becomes more grounded and informed.
Let's now bring in two quick-fire commentaries. First, from a bioethics perspective, here's Dr. Nancy Cho from Stanford.
Ethical triage requires both utilitarian reasoning, maximizing benefit, and deontological values, respecting dignity and rights. AI can enhance the former, but often struggles with the latter. The future lies in hybrid governance models, where clinical ethics committees, not just code, guide deployment.
Powerful point. Now, from a critical care nursing perspective, here's Lauren DeVries from Massachusetts General Hospital.
We're the ones at the bedside after the triage call is made. If the decision lacks compassion or seems cold because it came from a system, families don't forget. AI must never replace empathy, even if it helps decide who gets a bed.
Thank you to our contributors. Let's close this segment with one final question to both debaters. If you could redesign the triage system from scratch, with or without AI, what would be your guiding principle?
Equity through enhanced capability. I'd build a system where AI handles the computation, but human clinicians oversee the ethics. It would be dynamic, real-time, and regionally adaptive. My North Star: maximize lives saved without compromising justice.
My system would start with patient dignity. Every decision would include both data and human narrative. I'd keep decision-making human-led, AI-assisted only where appropriate and always transparent. Technology should serve people, not displace them.
Well said. The tension between heart and code continues. Coming up, final statements. One last chance for our debaters to make their case. We now enter our final segment before they give their final statements. Each debater will have 3.5 minutes, uninterrupted, to make their closing argument. Dr. Delgado, you go first.
Thank you. Tonight, we've debated a question that isn't just about algorithms. It's about life, death, fairness, and trust. Let me be clear, I'm not here to say AI should replace doctors. I'm here to say that when used responsibly, AI can help doctors make better decisions. In times of crisis, like a pandemic surge or mass casualty event, there's no room for guesswork, fatigue, or bias. AI offers consistency, speed, and scale. We already use tools like SOFA, MELD, and Apache scores. AI simply refines and accelerates what we're already trying to do: allocate care wisely. Unlike static formulas, AI can learn, adapt, and improve. It can spot patterns we miss, it can highlight outliers we overlook, and yes, it can be made more fair if we commit to designing it that way. We've heard about the risks, they're real, but rejecting AI outright because it isn't perfect would be like banning antibiotics because of resistance. The better path is regulation, transparency, and human oversight, not fear-driven rejection. In Triage, our goal is clear: save the most lives with the most dignity. And to do that, we must embrace the tools that help us rise to the occasion. AI won't replace us, but it might just amplify our humanity.
Thank you, Dr. Delgado. And now, Dr. Bennett, your closing argument.
Thank you. Javier speaks with conviction, and I respect his passion. But I stand by this. No machine can understand the full weight of a life. Yes, we need tools. Yes, we need help under pressure. But when you ask me who should decide who gets the last ICU bed, I say it must be someone who can ask, who is this person? What do they value? What story does their life tell? AI doesn't ask those questions. It crunches data, past outcomes, predictive models, proxies for probability, but it doesn't see the whole patient. It doesn't feel the pause when a family says, please, just one more day. And let's talk equity. Data reflects our systems, and our systems have deep-rooted bias. AI can mask that bias in mathematical neutrality, but under the surface, it's still there. Injustice, coded into the code. Triage is not a math problem. It's an ethical act, wrapped in compassion, nuance, and sorrow. We need tools, yes, but tools don't have conscience. We do. My vision isn't anti-tech. It's human-centered. A system where tech supports, but never supplants the judgment of clinicians who know that medicine is about more than survival. It's about meaning. In the end, AI might help us predict who could live, but only humans can help us decide how we want to live and die.
Two powerful visions, two compelling voices. You've heard the data, the passion, and the principles. Now it's your turn to decide. Coming up next, our final segment, Expert Reflections. To help us close, we're joined by two esteemed voices for brief reflections. First up, Dr. Layla Monroe, Professor of Medical Ethics and Director of the Center for AI and Justice in Healthcare.
Tonight's debate underscores something essential. AI is not just a tool, it's a moral actor by proxy. We must treat it as such, designing systems that reflect our values, not just our efficiencies. I think both Dr. Delgado and Dr. Bennett made powerful points, but the key lies in integration. AI must be transparent, governed, and never left to function in moral isolation.
Thank you, Dr. Monroe. Now joining us from the ICU at Mount Sinai is Dr. Ethan Choi, who's led triage teams through 2 pandemic waves.
In the trenches, we crave anything that helps us make clearer, faster decisions. But I've also seen the cost of disconnection, when families feel their loved one was just a number. AI can offer incredible support, but I still believe the last call should come from a clinician who sees the patient as a person. Let AI whisper, but let a human speak.
And with that, we wrap up today's high-stakes debate. Huge thanks to our debaters, Dr. Javier Delgado and Dr. Aisha Bennett, for their clarity, courage, and conviction. And to our listeners, thank you for bringing your curiosity, your clinical experience, and your moral compass to the conversation. If you found this episode thought-provoking, share it with your team. Reflect on it during rounds. Debate it in your own hospital ethics meetings. We'll be back next week with a new topic, a new face-off, and another deep dive into the front lines of medicine's technological transformation. This has been Humans versus Machines, the medicine debate, where every bite meets a heartbeat.